Welcome to Team Gut Girls, the podcast for anyone who's ever unbuttoned their jeans at 10 a.m., mapped out every public washroom in a 10-kilometer radius, or wondered why one bite of food can ruin an entire day. We talk about bloating, constipation, diarrhea, reflux, nausea, abdominal pain, histamine chaos, and all the quiet gut symptoms you're told to just live with. Join naturopathic doctors Dr. Whitney Baxter, Dr. Christina Carew, and Dr. Dominique Vanier. Your gut is talking, and we're here to help you translate. You're with Team Gut Girls now. Let's dig in.
And before we dive in, just a quick note. This podcast is for educational and informational purposes only. It's not meant for medical advice and doesn't replace working with your own healthcare provider. We're sharing general information, not diagnosing or treating anyone. Please always talk with your physician or licensed healthcare practitioner prior to making changes to your health, medications, or supplements.
Welcome to another episode of Team Gut Girls, where your favorite naturopathic, gastroenterology, gut-focused doctors come together to dispel myths and help you to understand what your doctor and the internet is telling you. I'm Dr. Christina Carew. I'm joined by Dr. Whitney Baxter and Dr. Dominique Vanier. And today we're going to talk about
something if you've ever felt uncomfortably full after a few bites of food. You might have felt like this before. It's quite common. Felt like food just sits in your stomach, or you're having some like higher abdominal pain, bloating, burping, or nausea, maybe some burning. This episode is for you. Today, we're talking all about a gut connection called dyspepsia and a bacterium called H. pylori. So these clusters of symptoms is referred to as what we collectively call dyspepsia. And one of the things that makes dyspepsia confusing is that it's not actually a diagnosis. You want to think of it more like a collection of symptoms. But there's actually an exception to this that we will go over pretty thoroughly in this episode. Functional dyspepsia is a real diagnosis. So let's talk about when someone develops dyspepsia. The next question is, why? And sometimes there is an identifiable cause. We call this organic dyspepsia. So we think about like organic dyspepsia. This is where we start when we're trying to determine what's going on with somebody. And we're going to look for things like stomach ulcers, if they are on certain medications that have led to these symptoms, gastric or even esophageal cancer. And one of the most common causes worldwide, which we are really diving into deep today, is Helicobacter pylori or H. pylori. And like Whitney just mentioned earlier, this is a bacterium that lives in the stomach. And in some people, it causes inflammation of the stomach lining. And that's where we see all these symptoms. It's really due to this level of inflammation that's happening. So we'll see things like upper abdominal pain, burning, nausea, indigestion. And because it's such an important cause of dyspepsia, current guidelines will recommend testing for H. pylori pretty much right away when patients present with these symptoms.
okay. So if someone tests positive for H. pylori, we have our answer. It's this whole reason why we have upper abdominal pain, bloating, burning, right?
Right. It's super simple, and our episode is now over, so we can go. This is where that gets a little bit nuanced. So sometimes yes, but it does get interesting. So many people with dyspepsia symptoms test negative for H. pylori. They may have gone on to have like an endoscopy, which is the scope that goes through the mouth into the stomach, into the upper part of the small intestine. And that can be normal. They don't have any obvious structural explanation for why they feel the way they do, but they still have symptoms. And that's where functional dyspepsia comes in. So it's not a structural issue. It's a functional issue. We've talked a lot about other functional digestive issues on other episodes, but functional dyspepsia is what we call dyspepsia symptoms that really can't be explained by anything else, other conditions that we have already worked up for. So interestingly, this functional dyspepsia accounts for up to 80% of dyspepsia cases in clinical practice. So today's episode, we're really trying to have a goal of helping you make sense of your symptoms. We're talking about when there may be an identifiable cause, such as H. pylori. Now, number two, why many people continue to have symptoms even when testing is normal, and what functional dyspepsia actually means. So if you're listening and you've ever been told, all your tests are normal, like everything's good, you look fine, but you are downing Pepto-Bismol like it is your job, you're sneaking into the boardroom by yourself and drinking Pepto-Bismol, this is the one for you. And before we get into a bit of myth busting, segments on, H. pylori dyspepsia, functional dyspepsia, I want to be really clear on what functional dyspepsia is. And so clinically, we do define it in a certain way. It's when somebody has one or more of the following bothersome digestive symptoms. So they may have this uncomfortable fullness right after they eat. They may feel like an early satisfaction or early satiety. They may or may not have this upper abdominal pain, and they may or may not have upper abdominal burning. So they can have one, they can have all. And also it's important that we have done a full workup and ruled out other causes. Okay, so with that introduction, let's go into some myths and misconceptions, and I'll pass it to you guys. We're going to talk a little bit about H. pylori and functional dyspepsia and where they overlap.
Okay, so first myth, a blood test is the best way to test for H. pylori. And so this one's actually kind of interesting. I actually did a deep dive on this topic because I was really curious. So where I live and where Dr. Dominique lives, it's very common that we'll see the medical doctors run an H. pylori blood test. But this is actually really rare. It's actually not run almost anywhere else in the country or in any other country. And so depending on where you're living, this may not even have been given to you as an option, but perhaps presented by ChatGPT. And the one thing about the blood test is it measures antibodies. And so an antibody says, has my body seen this infection ever? It doesn't necessarily mean that it is today. It doesn't mean that it was, 9 days ago or 9 months ago. It just says that, my body has seen this infection at some point in time and it recalls seeing it because we're getting this pattern that's showing it. And so the way that this blood test is sometimes used in practice is that people will be like, well, if you've never been treated for it before and this test is positive, you may as well be treated. And so that may or may not be the best option for someone to pursue because the treatment for H. pylori, if you've ever had it, is pretty invasive. So it's a lot of antibiotics. It's for a long 2-week period of time. Most people feel terrible on them. And it doesn't always get rid of your symptoms. So keep that in mind. So the preference is actually a stool antigen test or a urea breath test. So those can still be performed at the same labs, depending on where you live. Sometimes those are covered under your health coverage, but not always. So it depends on where you are. Typically, if someone in my practice shows up with a positive blood test, I'll send them for the breath test just to make sure before we give you a whack of antibiotics. And so sometimes another way that it can be diagnosed is an endoscopy. So an endoscopy is a camera that goes down into your esophagus and into the stomach, and it's actually looking for evidence of this bacteria inside the stomach lining. So they do a biopsy for it. And it's not really a perfect testing method because when we think about the stomach, so our skin on our body, we can have a rash on our elbow, and if someone looks at our knee, then it's not necessarily going to help us. And so the stomach is like if you took your comforter and pushed it all together into the size of a hot water bottle, and then you try to look at it and be like, oh, is there something in there? It's not always the greatest way to be able to visually see something. Sometimes it's really obvious. It's like in a part of the stomach that's easily locatable, but not always. And so these other tests, which rely on making a gas or seeing a bacteria in the stool, are a little bit more reliable because they actually don't care where someone looked in the stomach lining. And so none of them are perfect. They do require you to either do the breath test correctly, get the stool antigen in the sample that it's there, or look in the right spot for the endoscopy. So, don't be alarmed if you get a negative, but still feel like you may have it. It may just not be its perfect test. But if someone is already taking medication like PPIs to prevent some of that heartburn, antibiotics, the Pepto-Bismol that Dr. Dominique talked to about earlier, that may also be another reason why sometimes we see false testing, either in breath, stool, or endoscopy testing. So just keep in mind there are lots of ways. There's also sometimes there's these stool antigen markers on these private stool lab tests, and just to be like conscious of those aren't necessarily similarly not detecting an active infection. They may have been detecting a past infection. And so you always want to be sure that the symptoms that you're having are aligned with an active infection before you add and bomb your NSAIDs with a whole bunch of antibiotics. It may or may not.
It's interesting. That's a good point there. I once had a patient where she was taking really high levels of ginger and a few other herbs, and she went for an endoscopy because she had all the symptoms for H. pylori, and it came back like she had a normal endoscopy, but she actually was infected. It came up as a false negative. So important, right? These tests are not perfect, although they're all pretty good. Other myths that we know of about dyspepsia or H. pylori.
I'll get into a myth all about stress, because we love talking about stress and how it impacts our gut. So a myth is stress can cause stomach ulcers, which cause dyspepsia. So all of those symptoms, the burning, the early fullness. Everyday physiological stress does not directly cause peptic ulcers in most people. The most dominant causes are H. pylori infection and actually NSAID use. So like Advil, these anti-inflammatories that people take for pain for whatever reason. But roughly 16 to 31% of ulcers have neither H. pylori or NSAID use as an identifiable cause, suggesting other cofactors, potentially stress, must contribute in some patients. So there is this group of people that this could be going on. As we've talked about a number of times, stress is not good for our gut. It just doesn't allow it to fully function and digest properly. So we're often left with undigested foods or improper release of stomach acids, digestive enzymes, poor movement or motility. It may not be the primary cause of your stomach ulcer, but it will exacerbate this functional dyspepsia.
Okay, myth 3. This one's a biggie. So if I'm H. pylori positive, but I don't have the symptoms that we talked about earlier, like the burning sensation in the stomach or stomach pain, you should not treat it. And so this is really a great debate. There's a consensus paper that was done in Asia that talked about how some Asian countries like Korea actually test all people who are 18 years of age. And if they're positive for H. pylori, then they treat them for it because they actually see long-term it reduces the amount of stomach cancers they have in the population. And pretty high prevalence of stomach cancer in the population as people aging. So this is like a preventative public health endeavor. We know that about 30 to 50% of people that have H. pylori are actually not symptomatic or not symptomatic in this like traditional way where we're seeing it. So sometimes there's some like weird things that come up. I had a patient that was positive for H. pylori, had a weird skin rash. There's their only symptom, but once they were treated for H. pylori, skin rash went away. So that was like kind of unusual. Sometimes people will have constipation from H. pylori, which is kind of interesting. We don't always see that because it's a bit higher up, but remember that like our gut is all connected. And so a signal in one place that's disrupted can make everything kind of change. We do know from the current research that about 2 to 6% increase, or you have a 2 to 6% increased fold chance, meaning like doubling to 6 times. 6 times it's hextupling. I'm sure I made that up. At risk of gastric cancer if you have a positive H. pylori infection, whether you have symptoms or not. And so you are increasing your risk of gastric cancer without it. And we know that gastric cancer, if anyone's had anyone in their lives that had it, is really hard to get rid of. And the incidence of death is pretty high. And so if we are able to treat it, and there is a large RCT that looked at 22 years after someone was treated for H. pylori, what was their chance of getting gastric cancer, and it was reduced by 50%. So not perfect, but certainly still helpful. And so our guidelines in America currently say if someone is positive for H. pylori, they should be treated with antibiotics. So a long way around of saying if you're positive, even without symptoms, you should consider getting treatment because it has some long-term effects that might be really worthwhile.
And people are often afraid of antibiotics, right? Like they don't want to take them if they feel good. Like, why would I take it if I didn't even know I had this? But using these numbers and the risks and just breaking it down for people, yeah, this is a really hard protocol. I want you to try to get to at least 10 days. I'm going to check in with you. And we just go for it. And it's hard, but people have had to buy because there's quadruple therapy. There's lots of medications going on. The like Monday to Sunday daily medication things just to keep it easy. Don't think about it. Just do your best. So just like supporting our patients through this protocol is sometimes the best that we can do.
And I think a good role that naturopathic doctors play there, because, at least in Ontario, all of those medications are out of our scope, but it's the education part. And I've certainly talked to quite a few patients where one of the medications in the quadruple therapy is a proton pump inhibitor, which is an acid reducer. And that's there for an important reason. It actually brings out the bacterium in its more active phase, we'll call it, so that it makes the antibiotics more effective. So if somebody's on it, we don't want to just take 3 of the 4, right? We want to make sure we're doing the full protocol if possible.
And we want to make sure that they do probiotics. There's some research around some other things that naturopathic care might include, like lactobacillus or NAC or biofilm openers that may actually make the antibiotics work a bit better. So there could be some things that could be additive that may actually improve someone's outcome of getting rid of it the first.
Yes. Yeah. So many other supportive roles there. Okay. So myth 4 is my endoscopy was normal, so therefore I don't have dyspepsia. And so, somebody, let's say that they've done the H. pylori test and that's negative, and at some point they're sent for the scope that we referred to earlier. And this is where it's a little bit confusing. So an endoscopy is going to rule out any of those primary causes of dyspepsia, like the ones we've discussed, H. pylori, stomach ulcer, etc. You want to think of it like those are the organic primary causes. But if somebody's endoscopy is normal, it can mean that they have this functional dyspepsia, and that is a disorder of gut-brain interaction. So we've talked extensively about disorders of gut-brain interaction, I believe episode 5 on this podcast. And people most commonly know DGBIs, or disorders of gut-brain interaction, as it relates to irritable bowel syndrome. Functional dyspepsia also follows under that umbrella. So when somebody has this functional dyspepsia, it means that they have all the symptoms like burning, bloating, stomach pain, and it's partially due to a miswiring between the way the brain communicates with the digestive tract. Now, what's also interesting is somebody can have a normal endoscopy. They may have dyspepsia symptoms, but they actually have gastroparesis, which is a totally different condition. And we have a whole episode on that as well. And Dr. Christina has spoken extensively about that in presentations to some of our colleagues. And that's where our stomach empties too slowly into the small intestine. So the point of this myth is that if your scope is normal, it doesn't necessarily mean that all is normal. It could mean that we have a functional condition happening. Okay, let's maybe dive into a bit more of the insight and education piece for the listeners. So I want to talk about why functional dyspepsia actually causes bloating. This whole series is on bloating. So we want to figure out why somebody would present with bloating. And, each one of us is going to discuss what's really going on in the body. So I'll start off. There's actually no single mechanism that explains why somebody would have bloating when they have a diagnosis of dyspepsia, but there's multiple things happening. And we want to think of it in these 6 key areas. So area 1 would be when somebody has functional dyspepsia, they have something called impaired gastric accommodation. And this is where the stomach is normally supposed to relax when we eat food. But in this population of people, the stomach basically does the opposite. So it doesn't appropriately accommodate the food that we eat during a meal, and that can lead to a few other things like this increased buildup of pressure, this early satiety, and a few other symptoms. What are some other mechanisms going on?
So we've talked about this a lot before too, but so it's not accommodating, but then it's not emptying effectively. So delayed gastric emptying. So this means that the stomach contents, so all that food that you just ate and it mashed up, is just going to sit there for longer. So you're going to get those signals back up to your brain that you're full. It makes sense that you could feel some bloating there. The resulting prolonged gastric distension, so this like physical pouching out, produces the bloating, the postprandial fullness, so early fullness after you eat, and then early satiety.
There's visceral hypersensitivity. So that's when we have a normal amount of gas, food, or distension, but it can be still felt as painful or uncomfortable, even though it's not exaggerated. And so part of this actually relates to our episode on mast cells. So mast cells are at the end of the nerve bundles. They create more sensation and sort of like turn on the fire alarms of things that are making our body perceive things as a threat that may not be a threat, but they feel like that. And so that sometimes is where we get some of the pain and discomfort. And then kind of that leads into that is duodenal inflammation. So there's inflammation inside the small intestine where the eosinophils and the mast cells, these sort of contributors to sensation, live. That inflammation can be seen as a contributor to functional dyspepsia. And one of the things that when we have more inflammation, we have more leaky gut. So we actually talk about that in episode 11. And so if you're now starting to see how like all of these conditions are becoming more difficult to pull apart from each other because there is so much overlap in what causes what.
And that's where things like visceral hypersensitivity and this like low-grade inflammation, these are consistent through all the disorders of gut-brain interaction. So we can start to treat these foundations for people, make like a huge jump, hopefully in progress, just to kind of like start to see some shifts and feeling better. Instead of, oh, we don't know what this is. It must be just must be IBS or must be functional dyspepsia. So there's actually concrete things that the research is showing that we can do, which is always exciting. So another piece we've talked about already in this episode and almost every episode is gut-brain axis dysregulation. So again, this is explained best by thinking there's a miswiring between the brain and the gut. So they're just yelling at each other inappropriately, that there's pain, we need to bloat now. There's something moving through our gut that's normal, even though it might not be at all.
Yeah. And the last point, and of course, again, like Dr. Whitney said, everything just kind of weaves into each other because one area will definitely affect the other, but we can see issues with peristalsis. And so sometimes, but not always, that's impaired in functional dyspepsia, and that's going to affect the speed at which things move from the stomach to the small intestine. It impacts motility, and then we're more likely to see gas and bloating. And we did reference an important point before, which is interestingly, it's up to 60% of people who have functional dyspepsia will have IBS. So we can see like this overlap of bloating happening from like lower digestion and upper digestion. And if possible, we want to be able to tease it apart because the treatment protocols are a little bit different sometimes for both. But for some people, they may actually have multiple conditions happening, which leads to some bloating.
Okay, let's talk about how to approach this for people. There's a testing algorithm, which is sometimes nice for us to see in the naturopathic medical world. We can like talk you through next steps and what to expect, whether you're going mostly through the conventional system because we cannot refer for imaging or scopes. So for dyspepsia, an important point is that the endoscopy is the gatekeeper. So whatever happens with that endoscopy, what that result is, that's going to diagnose all types of dyspepsia, and then you'll know your next step.
And I did a presentation on this a little bit recently because it's really that scope. And so again, it's out of the scope of naturopathic doctors, at least in Ontario. But when the decision is made by somebody's family doctor or even gastroenterologist to do an endoscopy, it tends to be based on a few different things. But the guidelines from 2017 for both Canada and the US do say that it has to do with age, typically, at least as a starting point. And so somebody who is above 60 and has these dyspepsia symptoms is much more likely to be sent for an endoscopy versus somebody who is under 60. And the majority of people will automatically be tested for H. pylori. And again, we talked a little bit earlier about, what that first testing may look like. It still sometimes is a blood test, but sometimes a stool test and sometimes a breath test. And if this is negative, then they will typically be given an empiric trial of a proton pump inhibitor. And that's the main acid blocking medication. So again, they haven't had a scope yet. They've been given a medication first to see if they respond to it. If they still have burning, stomach pain, bloating, etc., only at that point are they often referred for an endoscopy. And there's certainly exceptions to this, right? If somebody has like a strong family history of gastric cancer, or if they're like in an area that has a higher rate of gastric cancer, that may change the decision-making process. But what I think is important here is that symptoms alone cannot distinguish organic dyspepsia from the functional dyspepsia, which is, again, more of a disorder of gut-brain interaction. And that's where the endoscopy comes in, but not everybody gets a scope. And so some patients sit in this like diagnostic dilemma, we'll call it, where we think that they have a functional condition, but we can't say for certain. We're going to treat it though, like they do anyway. So let's maybe go into when people are recommended a PPI and how that looks and kind of the timeline there. And I'll pass it to Christina for that in terms of what happens when somebody is given a PPI.
Yeah. So as Dr. Dominique referred to, sometimes you're given a PPI. So they usually end in azole, lanzaprol, pantoprazole. They are usually in this PPI family, which is a proton pump inhibitor. Sometimes if you have an allergic reaction or not sensitive to those, you may be given an H2RA, which is a histamine 2 receptor antagonist. Both of them are designed to lower the stomach acid in hopes that whatever is contributing to the symptoms when the stomach acid is lower just has an opportunity to heal. So think of it as like a rest for your digestive system in some ways, where your body has this opportunity to heal because it's not being irritated by the acid. And it should be a temporary measure. So most of the packaging instructions say, use this for up to 3 months. And what ends up happening, lots of times the patients that come into our practice might have been on for 25 years, 30 years. And so, is that an appropriate use of the medication, and what are some outcomes? We know that there are some other things that we need to worry about from a long-term care use. So certainly they have been associated with increased fracture risk, increased risk of C. difficile, low magnesium, renal disease, bone issues. So certainly because we're reducing the amount of absorption from our food because that acid isn't breaking it down as well, we might be missing some of the nutrients. And often once you're on one of these medications, people forget to go back and check for those things. And so that would be one important thing that you can advocate for yourself. And there aren't really guidelines when to discontinue it. And so often I actually have a physician who's a patient who came in one day and slid across this piece of paper, and there's like 25 medications on it. And I was like, looks like you got it all figured out. And he's like, I don't even know how to get off any of these. And so I would say like we're really good at understanding when patients need to be on something or trial something, but we're not really good at knowing how to take them off. And so there are some pharmacists that can help with that. There are some other practitioners that can help with that. But, typically coming off the medication, depending on what kind of medication is very different than going on it. So sometimes it's reducing the dose. Sometimes it's discontinuing altogether. Sometimes it's changing to different medications. So don't try to do this on your own. But there may be some benefit in trying to come off of it. It doesn't mean that all those symptoms are suddenly going to come back if they were gone. It may actually have resolved itself and you're just continuing to take the medication without really a need for it.
Conversation, I think, is starting to happen a little bit more. But I mean, if it's possible that somebody has an exit plan when they start a medication, then that's important too, right? Yeah. Okay, let's maybe talk a little bit about some practical takeaways, some accessible things that, the listeners can possibly DIY at home, or at least be more mindful of regarding symptoms and what they're eating. We want to keep in mind, though, that like functional dyspepsia is heterogeneous. And what we mean by that is no two people are going to look exactly the same that have functional dyspepsia. So something that's going to work well for somebody may not work as well for the next, or vice versa. So it's really important to work with, your practitioner, naturopathic doctor, and find the right plan that fits for you. But let's dive into maybe some food, pain, and then brain gut therapy. So we'll start with food.
So food can be challenging, right? We've talked previously about taking all the foods out of the diet and then being mindful of the fear of putting them back. And so we always want to be careful around that. And there are some sort of like universal things that are often told to people who are having dyspepsia symptoms, like stop citrus or stop coffee or don't have tomatoes. And sometimes I would say that people come back in like, well, I've never tried that again because someone told me to take it out. Back to our discussion earlier, I think that was in episode 4, that being mindful of how a food makes you feel is really important, but not excluding everything because, we're both missing things that we might get nutrition from, but also be missing things that we just enjoy. And so food should be about eating and about having a good time eating and not just like literally being stressed out about eating. So there are some dietary changes in this case that may help. Sometimes being mindful of if you are taking that medication that lowers the stomach acid, that may make some foods feel more triggering at a time because they're not breaking down as well. Also be mindful of like other medications that you're taking that may also exaggerate that. And so tracking your diet as a starting point without taking anything can be a great way to kind of just see if there's any commonality. And sometimes it's actually something super underlying. So it might just be foods with more fat in it, not that it is eggs or potato chips or avocado that's making the issue. It's just like, in general, if I eat more fat, I have more difficulty with nausea, bloating, fullness, pain. And so if we can identify food category like that, then we may also have a food category solution. And so we know that if we have better bile, if our body is able to break down fats a little bit better by sometimes partnering them with other foods, we may see that that body is actually able to eat those things. It may be actually a volume piece as well, like how much of that are you eating? So if you're on a keto diet, it's very different than if you're adding it as part of it. And we do know that some things like FODMAPs have been studied to improve functional dyspepsia symptoms. Challenge again is that when we take all of the fiber out, then, we can actually slow down the transit system, which may make the bloating worse, but some of the other symptoms better. And so always being mindful that tracking your food can be helpful, but nothing's ever an absolute, and nothing's ever absolutely the same for every person.
Okay, so let's talk about some things that are going to help that stomach empty more effectively and then decrease the pain. So again, like Dr. Christina alluded to, really working with your practitioner so we can hear like your history. What's making it worse? What have you tried? What are your symptoms? Because some things, though they've been studied to help, for example, ginger, it's great. It helps the movement of the gut. It increases gastric emptying, so that's stomach emptying. It's an anti-inflammatory. It's used in pain, but it could trigger some like burning or some discomfort. So just really working with your practitioner. Maybe you do a little test dose, make sure it's not flaring anything up. And then peppermint too. They're like enteric-coated peppermint capsules. That can be really, really great. They really relieve pain and many DGPIs. So I like those. And then probiotics. They can promote our ecosystem of microbiota and that gut-brain modulation, which may help reduce the pain and bristle hypersensitivity just from that like micro-inflammatory standpoint along the gut mucosa.
Yeah, there's so many other great herbs that can definitely help. And then, but also sometimes like they don't, right? Or sometimes they help in one area. And then, for example, people that have concurrent reflux may be aggravated by peppermint. So again, important to work with your person who knows what they're doing. Another important takeaway that we've talked a lot about is the brain gut connection. And so there's many well-researched therapies in this area, and that can, you want to think of it like that can dampen some of these pain signals that are being sent to the brain from the gut. So things like gut-directed hypnotherapy has a lot more research behind it now than it did even 5-10 years ago. Cognitive behavioral therapy. I know we've talked pretty extensively about diaphragmatic breathing and how that is supportive for the nervous system. And again, it's about the central nervous system aspect or mechanism behind the pain in some people with functional dyspepsia. So often with like the recommended treatment plans is really working on how the brain communicates the gut is part of it for at least for some people. And then, like we mentioned earlier, we want to talk about whether there's anything else going on, like a lower and upper digestive condition. So for some people with dyspepsia, they're also going to have that concurrent irritable bowel syndrome. And if they're experiencing constipation as part of their IBS, is that actually may worsen functional dyspepsia. So important to figure out, do we need to move the bowels even a little bit better to see improvement higher up? Okay.
Also add to this is like hiatal hernia. So hiatal hernia can present like functional dyspepsia where we're getting symptoms, and sometimes it's really challenging because in a hiatal hernia, the diaphragm is supposed to keep the esophagus from and stomach from bunching up together, essentially. So it's like a level or a shelf that keeps the stomach below the surface. And if the hole that the esophagus goes through is like overstretched, then the stomach can come through the hole. And so why that sometimes is hard to diagnose is because on a gastro exam, like an endoscopy, it may not be happening right at that moment. And so it's like a thing that happens over time. It's like running and you pull your hamstring and then you finally get into the physio and you're like, well, it actually feels okay today, right? It's like, those things can shift and change. It's not that you can't have that whole overstretch where the stomach is coming up through the diaphragm. It's just like when you're lying down under anesthetic on a table, it may actually not show up. And so some of these might be things where you do need to see an osteopathic practitioner, physiotherapist, someone who can see you be quickly and also in those moments where you're getting some of the symptoms. And because there could be some functional pieces behind it that we didn't discuss here that may be contributing to the symptoms. And so this is, the only thing that might be happening if you have dyspepsia symptoms. So keep that in mind.
The gut can be like the wild, wild west for some people because they can have a hiatal hernia and they can have no symptoms at all. So yeah, it's this is where the testing and the workup is important. And so on that note is when we are talking about this with our practitioner, let's say somebody's had, chronic symptoms that we've discussed earlier, and they're really looking for help on this, is what are some kind of key takeaways that they can use, or what are some points that they can bring to their practitioner? And even before they have that meeting, I think tracking is really important. So this is helpful for your practitioner because it shows that you've been collecting some data for a certain amount of time. So for example, paying attention to whether there's early meal fullness, whether somebody's having pain or burning, and is that happening independent of meals? Is it happening with meals? And also noting what makes it better or worse. And that would be paying attention to food, if it's exacerbated by stress, if you went on vacation and you felt better, if you felt worse, things like that.
It helps you to really understand when things are starting to feel better too, right? Like if there are subtle changes after, you I noticed I have a lot of high fat foods. I didn't think of that before. And I started this treatment and that's getting a bit better. So these subtle things that you can track really help just document progress. So here are some questions that you can ask your practitioner, some more specific things. So have we ruled out H. pylori? And what tests did we do? So just a reminder, there's the serum or the blood test, the breath test, and the stool test. So they're not all perfect, but we tend to lean towards the breath test and the stool test. If the PPI isn't working, that proton pump inhibitor, what are my next options? Should I try something to speed up the gut? So prokinetics, neuromodulators. So those are things like anti-anxiety medications that we're using at a lower dose to help that pain, that gut-brain interaction. Is there anything I should try to remove in my diet? How long should I be on this medication before we reassess? It's really asking clear, what is the plan? What is the taper up and the taper off? Is there a role for dietary changes? Is my stress contributing, or are there any supplements that have research in my case? And then finally, should I see a gastroenterologist, or can this be managed in primary care?
And then making sure you tell your practitioner if there are any red flags. So red flags are things like weight loss, vomiting, trouble with swallowing, not able to eat even once a day because you're finding that it's too irritating. So sometimes people will go on extended fasts, making sure you're telling someone that. If there's any blood in your spit or vomit or anything that's coming up from blood coming out where it shouldn't be, perspective. Any family cancer history, any kind of issue with pain or discomfort in the throat or the esophagus area may trigger some more urgent care. And what we'll do is actually put a lot of these into a handout that you can download off teamgutgirls.com. And then that way you can kind of use that to track and bring into your physician so that you have some more information and you feel a little more empowered to be able to find out what's going on.
We have so many great resources. So let's wrap up this episode. I want to leave listeners with 2 quick recaps. Number 1, if someone has stomach pain, early fullness, burning, and other upper digestive symptoms, we want to rule out whether it's caused by something else like H. pylori, or if it's a functional issue. So it's not a structural issue, it's a functional issue. And point number 2 being regarding the functional dyspepsia, you cannot fully treat the gut without treating the brain, and you cannot fully treat the brain without treating the gut. We want to look at the whole thing as basically one system because they are so intertwined and impact each other. So thank you for joining us today on another episode of Team Gut Girls, because better gut health changes everything.
Thank you for joining Team Gut Girls. Like, follow, subscribe, and share our podcast with friends you think will want to know more about their gut. You can also visit us at teamgutgirls.com for show transcripts and more information, because better gut health changes everything. See you next time.